Good afternoon, everyone. Well, it's been quite a stimulating day so far, and quite a stimulating weekend for me. I went to the rugby last night, and here I am, another stimulating event. And it gives me a great pleasure to introduce to you Dr. Gwyn Lewis. Now, she's come down from Auckland this morning, and she's at the AUT. And she's going to talk to you today, as you can see up here by the PowerPoint presentation. She's going to talk to you about the potential effects of brain stimulation for chronic pain. Now, Dr. Lewis is a senior lecturer up at AUT, and the work she's discussing today has recently been funded by the Neurological Foundation, so please join me in welcoming Dr. Lewis to speak to you today.
Cool, thank you for that introduction, and also thanks to the Neurological Foundation for flying me down here today, even though it did mean a 5 o'clock start to get to my flight. I'm going to talk to you today about a project which has been recently funded that we'll undertake in brain stimulation for chronic pain. But before I get there, I'm first going to tell you a bit about pain and the pain system. So I'll give you a definition of pain. I'll give you what will hopefully be a nice simple explanation of the pain system and how it works. And then talk about why some people develop chronic pain and some of the reasons why that occurs. And then I'll mention some of the current management mechanisms for chronic pain, how it's treated now, and some of the benefits and limitations. And then I'll add in brain stimulation to that and talk a bit more about the project that we will be doing. Okay. This is a definition of pain. The IASP is the International Association for the Study of Pain. So this is what they define as pain: an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And I just want to highlight a few key words in here. Pain is unpleasant. We don't like it. It's not a nice feeling, and there's a reason for that. That's really beneficial, because pain tells us that something is wrong with our body. There's been some damage that's occurred. So if we put a hand on a hot stove, we get a really unpleasant sensation, so we remove it. And it draws our attention to that. Okay, so that sort of pain, the fact that it's unpleasant, is very useful. If we put a hand on a hot stove and it felt like this, we're not going to take our hand away from it, we're going to leave it there burning. So it's beneficial that this type of pain is unpleasant. It's also both sensory and emotional. We have two quite distinct components of the pain system. The sensory component tells us how much something hurts and where it hurts. But we also have a separate emotional component. So that means that pain can make us sad or anxious or fearful. It influences our emotions. So that's why it's unpleasant. Okay, so when we have an experience of tissue damage, we'll say, that hurts quite a lot and it's in my elbow. But I'll also get a behavioural response to that, and I might be quite upset by that. It might make me quite depressed. Okay. So there's an emotional component to it. This last part here, it says it's associated with actual or potential tissue damage or described in terms of such damage. This means that we can experience pain without any physical tissue damage, and that is still pain. So in these conditions, and I'm going to tell you and give you some examples of why this arises coming up. So in this case here, you can't see any physical damage whatsoever, and yet people still experience pain and report sensations as though there is, like most of the time this occurs, there's stabbing or shooting sensations that they're reporting. And that is still perfectly legitimate pain. Okay. So pain's nasty, it influences our emotions, and we can experience pain without tissue damage. Okay, Descartes first described the pain system way back in 1664. He had a very simplified view of it. He saw pain as a very stereotypical response which correlated to the amount of tissue damage that was occurring. So this person here, if their little toe was being burnt, the message would get sent up the spinal cord into the brain and they would experience a small amount of pain. If the whole foot was being burnt, they would experience more pain. And that was this very simplistic view of how the pain system worked. We now know it's a bit more like this. Okay? There isn't just one pathway going up, and there's a lot of pathways that come back down. Okay? The pain system is incredibly complex, and I'm only showing a component of it in here. And we've got lots of things that turn pain up and turn it down, and it gets modulated by lots of things. So it's actually a very complex system. The more we study it, the more we realise how complex it is. And it's no wonder in a system like this, it's no wonder that things go wrong. You know that with any high-tech new gadgets that have all these fancy devices, it's really easy for them to go wrong because there's lots of places where things can break down. I have a slightly simpler description of the pain system. This is what we'll use today to describe to you why we experience pain. So out here in the periphery, in our tissues, so in most tissues of the body, we have sensory receptors that detect tissue damage. They're our pain receptors. So pretty much every part of our body will have pain receptors in them. So they're out here in the periphery. They send signals into the spinal cord, and then from the spinal cord they go up to the brain. This part here, this is the brain stem. It's actually just up in here. I've pulled it out. It's a key site where we can influence the amount of pain that we have. So I've pulled it out down here. But it goes up through here and up into the brain. And it's when the signals get up here, that's when we experience pain. So we might have some damage down here, comes in here, goes up, and we experience pain when it gets up to there. What you'll also notice is that there are pathways that come back down again. So some start in the brain, some start in the brain stem, they come back down here into the spinal cord. So that tells us that we have ways that we can modulate or we can influence the amount of pain that we experience. Because you know that the same type of injury, you won't get the same amount of pain every time, and it will vary a lot between people and the context of when it happens. If you were out on the sports field and got a tiny little cut on your foot while you're running around playing rugby, it's going to be very different. You probably won't even notice it. But if I stood next to you and had a bit of paper and we got your finger out and I gave you a paper cut, that's going to hurt a lot. So that same type of injury, the experience that you get will be very different depending on the context in which you get it in. Okay, so we have lots of ways we can influence pain. The first part is down in the spinal cord. So down here we have this great big dial. And this is here we can crank pain up or we can turn it down. So the signals come in here and they get to this dial and we can make them really, really high. When we first get injured, we turn it up as much as we can. We turn this dial right up to the red zone because we really want to make sure that we know that something painful has happened and that we need to do something about it. So if you're running along and you sprain your ankle, these little sensors down here, they light up and they send commands in, and the first thing this dial does is says, oh, I need to stop running. So it turns it up so we experience a huge amount of pain. Over time, we want to be able to turn that down again because we want to make sure that we get active. So we can turn it down. We can put it back down to the green region and say, it's no longer useful for me to get those signals. I need to recover and start getting active again. So we can turn it down there. Up in this part in here, in the brain stem, we have some cells. Some very nice person called them on and off cells. The on cells turn pain on, and the off cells turn pain off. It's very nice and easy. So they go down to that dial. So they can control that dial that's down in the spinal cord. So when these guys are active, they'll send a command down and the dial gets turned down. When the on cells get activated, they'll send a message down and the dial gets cranked back up. So they sit in here in this part of the brain stem. This is a slice through the brain, through this way. This part here, this is where those on and off cells live, just in this part of the brain stem in here. All those other yellow regions are the parts of the brain that are involved in experiencing pain and interpreting pain. So there isn't just one pain centre in the brain. There isn't one place that is fully responsible for the interpretation of pain. It's quite an integrated matrix. We call it a neuromatrix. This little component up here, this is the primary sensory cortex. That's the part that tells you where it hurts and how much it hurts. But these other regions, they're part of the limbic system. So that's involved with our emotions and arousal. So that means, no, they're all heavily interconnected too. So you'll see there's lots of arrows going backwards and forth between all these regions. So it really is a true network that they all talk to each other. So that means that when we experience pain, it will influence our mood. It can make us anxious or fearful. Our attention gets drawn to it. Okay. So that's the emotional component, because these are the parts of the brain, they're involved in this, and the pain messages go to that part. What you'll notice is that these regions all connect back up into this place here where the on and off cells were. So that means that as well as pain coming up and influencing our mood and our emotions, our current mood and our emotions and fears can also influence pain, because they can turn on the on and off cells in here. So if we're in a low mood, if we're depressed, we experience more pain. If you're anxious about it, you'll experience more pain. If you're fearful, if you're worried about a particular movement, if you bend over, you've got back pain, you bend over and you hear a clicking noise, and you become worried about that, you will experience more pain. So all these regions up in here, all these things can influence the amount of pain that comes up. And pain is very strong at driving memories. If you do something that hurts, if you put your hand on the hot stove and burn your hand, you never do that again. You learn very quickly. So it's very good at making memories. Okay, so pain comes up and influences these areas, but these areas will influence the amount of pain we experience. We also have lots of little factories I've tried to draw in here, little chemical factories within different parts of the nervous system which produce chemicals that can modulate the amount of pain that we have, and they're throughout the pain system. So for example, out here in our tissues, we can release chemicals, these inflammatory chemicals, so when you have inflammation you release these chemicals and they make our pain sensors more sensitive. So it means they're much easier to fire. So we call that peripheral sensitization. It's one of the mechanisms that we use early after injury to try and increase the amount of signal that's coming in. So we can produce these little chemicals down here. We also, most of you have heard of opioids, drugs that we take for pain. We produce our own opioids. We have our own internal opioid system. The reason that external opioids work is that because we produce our own, we have receptors for them in all these different areas of the body. So these little factories, we produce our own opioids as a way of inhibiting pain. We genetically determine the types of opioids that we produce and the number of receptors that we have, and that becomes important later on. So in some people, this factory here might work really well and produce lots of drugs, whereas this one here might not work very well. Okay, so that was the pain system in a nutshell. I just spent this last week teaching a 4 days course on pain to my postgraduate students. So we had 6 hours a day for 4 days, all on pain. It took me 5 hours to describe the pain system. You got the 5-minute version. You won't be getting any tests on it afterwards either. Okay, so I said that pain is useful. So pain tells us about damage. But there are cases, if we keep on experiencing pain, then it's no longer useful. We define chronic pain as pain that persists for more than 3 months. So sometimes something goes wrong with this system, and if you've had an injury, it's recovered, there's no longer any physical damage, and yet you still continue to experience pain. And when it becomes chronic pain, it's no longer useful. It's maladaptive, because it stops us from doing things. It stops us from moving when you have chronic pain, and that's not a good thing. And there's a number of reasons why you can develop chronic pain. And one of them, if you have constant stimulation of these pain receptors, and a good example of this are inflammatory conditions such as arthritis. So in arthritis, you're constantly sending in signals into the spinal cord here. And what happens is this dial up here, it goes a bit haywire and it gets stuck in the red zone. It's getting constant information coming in and trying to amplify it all the time, so it ends up stuck in this amplified state. And that's called central sensitization. Some of you might have heard of that term, central sensitization. It means in the spinal cord, those signals are being wound up. And it can start out that if you had knee osteoarthritis in your right knee, it might just mean that you become really sensitive about your right knee. But that sensitization can spread. Each level of the spinal cord has its own little dial, and they talk to each other. So sometimes that can spread up and down the spinal cord and across to the other side. So you might end up that you're now also more sensitive in your left knee, and then it might spread up to the trunk and to the arms. When that happens, we call that widespread central sensitization. Now, in that particular case, there was some type of physical damage. We've got arthritis, we've got tissue degeneration, and it's stimulating our pain receptors. But there are also a number of other chronic pain conditions where there is no tissue damage. It's the pain system itself that's at fault. Something has gone wrong with it. And I'll explain a few of them here. So this is a normal system. This is what normally happens. Here, this is out in the periphery, and this is a painful pin prick coming here. So we're stabbing ourselves in the skin. It activates this pain receptor here. So it sends a command into here. This is our spinal cord, so our little dial is sitting in here. That neuron, it releases chemicals, neurotransmitters, to activate this neuron here. This one goes up to the pain regions in the brain. Okay. So when that happens, it gets up to the brain and we say, ouch, that hurt. Okay. That's normal. If you have some damage to this pain receptor here, so down in here I've shown this is my little yellow explosions here. If you've got some damage, some nerve damage, and that can occur following surgery, it can occur in some traumatic events. Whiplash is a good example, where often you can have minor bits of nerve damage. Or if you've had a neural condition, a neuropathy, where parts of the nerve may degenerate. Sometimes you can get spontaneous firing. So these guys here, along here, this just starts firing. So nothing at all is happening out here, but these guys spontaneously fire. It sends a command in here, neurotransmitter is sent across to that neuron, and the signal comes up to the brain. And we say, ouch, that hurt. But nothing at all has actually happened over here. There's been no physical damage. It's just the nerve is broken. Now, nerves, we don't just have one type of neuron, one type of nerve in a nerve branch. We have lots of different types. This green guy here, this guy is sensitive just to normal touch and pressure. Okay, so he's a normal mechanical receptor that just tells us about touch and pressure. What can happen if that nerve is damaged and we get a nice stroking sensation on our arm, it's going to activate the green guy here, but come along to this part where the nerve is damaged and the signal can cross over. It jumps over to the other side. So it's like having two wires where they've lost their insulation and they're touching. The signal jumps over to the other side, and it means now that this neuron here is now sending a message in, and he releases his chemicals, turns on this guy, message goes up to the brain, and we say, ouch, that hurt, when all it was a gentle stroking sensation. What else can happen is that sometimes if these guys, if something happens to them, they can pull out from the spinal cord, they can die away. And these guys here, this is the green guy that just tells us about normal sensation, touch and pressure. He comes in and he invades the space in the spinal cord. So he now starts talking to this little dude here. So, nice stroking sensation on the skin, activates the green guy, but he turns on both of these neurons now. He activates this one, so this one sends its little command up to the brain and we say, ouch, that hurt. And again, all it's been is a little stroking sensation on there. And it's occurred because this neuron here has taken over and invaded in here. Nothing at all has happened bad out here. Our final mechanism is, we remember the on and off cells that came down from the brainstem. It's genetically coded how well they work. So some people have really good on cells, some people have really good off cells, and there's a bit of a mixture. What can happen in some cases is that if your on cells are overactive, it can mean that crank gets turned up and it turns up the signals quite a lot. But sometimes, if you've got a really overactive on cell up here with not much off cell activity, just these on cells, they can turn this on here, this neuron on. So nothing had happened over here at all, but because our on cells are overactive, They produce lots of chemicals, activates this guy, it goes up to the brain, and you say, ouch, and nothing has happened there. So in all those cases, someone experiences pain, and it's exactly the same pain sensation as if you had been stabbed in the skin out here. Feels exactly the same. Normally, the sensations that you get when it's come from nerve damage are quite sharp, shooting, painful sensations, hot and cold, painful hot and painful cold shooting sensations. We call that neuropathic pain. Okay. So neuropathic pain occurs when it's arisen from some sort of damage or disease to the pain system itself. So in all those cases, you're experiencing pain, but there's no physical damage out there. Okay, so those are some of the reasons why we can get chronic pain. I'm now going to quickly touch on some of the current pain management strategies, just very briefly, and try and show you how they work. Pharmacology, I talk about drugs, physiotherapy, and psychology. Okay, so most people who have a chronic pain condition will be taking some type of drugs, and in a lot of cases they'll be taking lots of different types of drugs. So what these can do is to sort of boost up some of our factories. So by taking opioids, what we're trying to do is stimulate those receptors that we have sitting there waiting for our own opioids, as we can activate them by giving other types of opioids. We have other drugs that can turn the on and off cells on, turn the on cells on or turn the off cells on, so we can modulate the amount of activity in there. We have other types of drugs that, if you've got neuropathic pain and there's some damage in the nervous system out here, we've got drugs that can stabilise those neurons so that they no longer spontaneously fire. So these drugs can all act in different ways. Some of them will turn down, the anti-inflammatories will turn down the inflammation out in the periphery out here, so we're not sensitising our neurons. So they all work in different ways. But I said before that we're genetically coded, the number and type of receptors that we have, so the same drugs won't work for everyone. And so often, if you start out taking some type of painkillers, your doctor gives you lots of different types, you kind of switch around until you find something that works for you, because you may have a completely different set of receptors from someone else. The drugs, they tend to work, but they don't obviously get rid of all the pain. They also have side effects, and some of them can be quite unpleasant side effects. We don't have a nice pure drug that only works on the pain system. And there can also be problems with addiction and intolerance, and that can be an issue with a number of the harder pain drugs. Physiotherapy is another really good treatment. There's lots of little tricks that physios can do that can make you feel better in the short term, but one of the best treatment or management strategies for chronic pain is exercise and movement and getting active. Activity is really important for trying to manage chronic pain, and it's normally the last thing you feel like doing. If you've got pain and you're aching, all you want to do is sit down on the couch and not move. But that doesn't help. You need to get active and to start moving. If you're sitting there and you've got your arm in a sling and it's not moving at all, what happens is you've got all these sensory receptors in here that aren't doing anything at all. So your spinal cord's not getting any information. It wants that information. It wants to know what your body's doing. So when you start getting active and moving, you start sending some signals back into the spinal cord, and it likes that, and it can help to normalise our little crank in the spinal cord there. It can turn it back down from being stuck in the red zone. We can turn it back down. So we can reduce sensitisation by doing exercise. And when you're exercising, it might hurt. And often people get told that, use pain as your guide. If it hurts, don't do it. That's not the case for chronic pain. For an acute, immediate injury, yes, it is a good guide. But for people who have long-term pain, pain is not a good guide for activity. And it's okay to experience pain while you're exercising, while you're being active. It doesn't mean that the damage is getting worse. It's okay to have a little bit of pain. Not a lot, but a little bit is okay. So being active and getting advice from a physio on what are the best types of movements to do and how should I do them, that can be really helpful. And psychological input is really very important for chronic pain conditions, because I told you about all these areas of the brain here that are involved in our emotions, our mood, anxiety, our thoughts and feelings, and that they talk to this little part of the brain here where our on and off cells are. So often it could be that someone's really stressed about something. Maybe it's their relationship. Maybe they don't like their boss or their work colleagues. And it could be that thing that is turning up their pain and making it worse. So having psychological input can be really useful and help turn on some of these areas and reduce the amount of pain that we have. Now, because those three types of treatment, the physiotherapy, pharmacology, and the psychology, because they all work on different mechanisms, one of the best treatment methods or management methods for people with chronic pain is to see a multidisciplinary team of people. So this could be a doctor, a physio, an occupational therapist, a psychologist, social worker you could have in there. And when you see a team of people, you become a lot more coordinated, and that the team are working together, and that you're not being referred from one person to the other. All the team are working together. And it also becomes very patient-focused. And it's not the physio saying, oh, I want to make their arms stronger. But the psychologist says, well, I want to make them feel happier. You've got one goal, and that's to do what the patient wants, and you work together as a team. So multidisciplinary team management of chronic pain is very useful. It can be quite intensive. There's a couple of places around in New Zealand where you can do pain courses which are 3 weeks. We don't have many in New Zealand, unfortunately. One of the reasons for that is they're very resource intensive and they cost a lot of money. So you think of all the people that have to be involved in the team. So they do work, but they're not readily available. So we need something else. We need some other way to help manage pain. Okay. So now we get into the fun part. Brain stimulation. Okay, brain stimulation for the treatment of chronic pain started in the 1990s, and they would insert, this is a tiny little electrode here, this is an American quarter, so it's a tiny little electrode, and they would put it directly onto the brain. This image up here, this is the brain, the skull's been taken off, the scalp's peeled back, down here is the brain surface, and you could see these electrodes put on. I found the nastiest, scariest looking picture that I could of these electrodes. When you have it for pain, you just get about 4 or 5 on a little strip of the brain, but it looked far better, this picture here. So you get these electrodes put onto your brain. And they found that, so these were people who didn't respond to medication, and they'd been through pain management programs and they still had pain. And so they did this brain surgery. So it's not the first thing you do, it's normally the last. And they found that in about 50% of the people, it reduced about 50% of the pain. So in half the people, it got rid of half the amount of pain, which was good. The effects did tend to wear off over time though. And it's obviously highly invasive and highly risky and very expensive. And you really don't want to be in the 50% that don't respond. You don't want to have brain surgery and get nothing out of it. But it did work. So, more recently, transcranial magnetic stimulation has been used, and that was mentioned in the talk earlier this morning. This is a way of non-invasively activating the brain. So we can change the excitability of the brain without having to go in and put electrodes directly on it. So with magnetic stimulation, you have an electric coil which generates a magnetic field, and then that magnetic field will excite the part of the brain that you're holding the coil over. And we can change the excitability of the brain doing that, using repetitive transcranial magnetic stimulation. This is what it looks like in the lab. This is the friendly clinic version where the person sits there smiling while they're having their brains out. Repetitive, so it's good, it's non-invasive. It doesn't seem to work as well though. People who had this only had about 10% pain relief. But what they did find is that people who had TMS and it worked, they then went on and did some implanted electrodes with them, and the implanted electrodes worked. Whereas the people who didn't respond to TMS also didn't respond when they had the electrodes put in. So it could be a good way of screening people and saying, is it worth doing the implanted electrodes for these guys? So yeah, it's okay. In New Zealand, there's probably 2 or 3 places where you could get repetitive TMS. And I did hear a pain patient that I had talked to. He said he talked to a guy in the States who had chronic pain and got this treatment. He got 1 week of this treatment, and they charged him $20,000 to have, which is ridiculous. This is expensive, but it's not that expensive. It shouldn't cost that much here. So it's okay. Now, transcranial direct current stimulation is what we use currently. Now, this is another way of non-invasively changing the excitability of the brain, but it's a bit nicer than the magnetic stimulation. Here, you put a couple of electrodes over the brain where you want to stimulate, and you tie them on, secure them down, put a bit of saline on them to make them nice and soggy, get good conductance. We've got this unit. They really do come in really nice pink and blue and yellow colours, so they look nice and friendly as well. It's a lot cheaper, and you can get take-home versions of these. There's probably quite a few places around New Zealand that have them, and we're hoping to get some of the take-home versions as well. So this was much easier. It's much simpler. It's much more practical. You don't have to sit in the same place and keep your head still while it's being zapped. You can put these on, and I think I've got okay. So there's been quite a few studies that have looked at how effective is transcranial direct current stimulation. So there's been 9 studies from when I made up this slide. There were 9 studies that had looked at tdcs. These are the populations that it was tested in. So there's quite a wide range of populations in here. It's been tested on a lot of conditions: fibromyalgia, people with spinal cord injury, pelvic pain, I think multiple sclerosis in there. So quite a large range of conditions. This is how long they turned it on for, 20 minutes on most of them. How many sessions they did, so between 1 and 10, but most commonly 5 sessions. So 5 sessions of 20 minutes of stimulation. But look out over here. These are the results of all the studies. Every single one of them has shown a reduction in the amount of pain. Some of them, not a lot, but some of them are getting up to 60%. And someone who has chronic pain, if you're able to say to them, we can reduce your pain by 60%, that would be fantastic for them. It would make a world of difference. I can guarantee you that within here, there'll be some people who don't respond at all, but there'll be others who have quite marked reductions in their pain. So it seems quite simple. One of the other benefits of tdcs is that you can do other things while you're having the tdcs on. As I said, you don't have to keep your head still with a machine over it. So there's been a couple of studies that have combined tdcs with other treatments. One of them did it for people with spinal cord injury, and they did an imagery kind of technique where they projected lower limbs walking while the person was having their brain stimulated. And they found that was really effective. So they're doing the imagery of themselves walking while they're getting the stimulation. Another study used it in combination with TENS. Some of you may be familiar with TENS, Transcutaneous electrical nerve stimulation. It's another way of treating pain. So they would put the TENS electrodes over the part of the body that hurt, put the tdcs over the head, and they found that the combination of those two was more effective than just doing either alone. So you can do other things while you've got them on. Okay, so how does tdcs work? We don't know is the answer to that. That's hopefully what we're going to try and find out. So this again is showing the parts of the brain that are involved in interpreting pain. When we do the brain stimulation, we target the primary motor cortex. That's the part of the brain that controls voluntary movement. This is the guy that interprets the intensity and the location of pain. And we know that the primary motor cortex talks to this guy a lot. There's a lot of communication. It also talks to this centre here. This is a thalamus, so the pain signals come up, go through here and up to here. Primary motor cortex talks to both these regions a lot. So it could be that the brain stimulation, we're activating the primary motor cortex and it's just stopping the signal. So they come all the way up here and then they get stopped at one of those 2 regions. There's that possibility. These are the other regions of the brain. These were our emotional areas out here. These guys, if you remember, they talk to this region where our on and off cells are. And the primary motor cortex also talks to these regions. So it could be that there's an indirect activation. We stimulate here and we end up tuning on our off cells through these areas of the brain. So it could be that we turn on the off cells and we're actually tuning down the pain somewhere down here in the spinal cord. And it was said this morning, it's really important that we can figure out why and how this brain stimulation works, because then we can sort out what sort of people will it be best with. If we know how it works and we know where is it in this particular person that their pain system has gone wrong, then we could say, yep, you're really suited to having tdcs. Okay, so our study. So I'll get on to our study. Yep. Okay, so why are we studying pain? In New Zealand, about 16% of adults will have chronic pain. So that's 1 in 6 adult New Zealanders has a chronic pain condition. And when you have chronic pain, you don't just have pain. You have impaired mobility. You can't go out and do the things that you want to do. It has a large effect on your emotions and your relationships. You might not be able to work. So it's a big problem in New Zealand. People who are older are also more likely to have chronic pain. People over the age of 75, more than 1 in 4 will have chronic pain. So the prevalence of chronic pain increases with age, and we know we have an ageing population. There are also ethnic disparities in the people who have pain in New Zealand, and more importantly is socioeconomic status. If you're in the lowest group, the lowest socioeconomic group, you're 3.5 times more likely to develop chronic pain than if you are in the highest group. And that's not good either. It's not good to have those disparities. So we're trying to use magnetic or transcranial direct current stimulation to see if we can come up with another method to try and reduce pain. So we're targeting people with neuropathic pain in their arm, upper limb neuropathic pain. We've got a couple of questions. So hasn't been trialled in New Zealand before, so we want to see if we do 20 minutes of brain stimulation for 5 days in a row, can we reduce people's pain and increase their arm function? And secondly, how does it work? Can we figure out what's going on? So what we're going to do, we'll get people in with arm pain, we put the electrodes on, stimulate the brain for 5 days. And then we're going to do a couple of measurements. We're going to measure the primary motor cortex, that part of the brain that controls movement, to see if we've changed the excitability. And we'll also measure the pain system, and I'll show you how we do that shortly. But one of the things that also came out this morning was the placebo effect. And that's a positive expectation that something is going to work and to be beneficial for you. So if I give someone who's in pain, if I give them a pill, if I put on a white coat, it would be even better. If I put on a white coat, give them a pill and say, this is a painkiller, it's going to be effective, give it 10 minutes and your pain will reduce. Their pain will reduce in 10 minutes. So they've got this expectation that they're going to get some pain relief. So we want to control for that. And one of the neat things about this tdcs, so when you turn it on, you get a warm tingling sensation under the electrodes, and then it disappears. You don't know that it's on. So we've done sessions where we've set it up to go for 20 minutes, and I've been chatting away to the person and looked over, and something's finished 5 minutes ago, because they can't tell that it's turned off. So that means we can be really sneaky. So we're going to have a second group of people. Same, they'll have arm pain, and they'll come in and we'll put the electrodes on, and these guys will turn it on for 20 minutes. These guys, we turn it on for 30 seconds, and then we flick the switch and we turn it off. So they sit there for 20 minutes with a couple of wet, soggy electrodes on their head that aren't doing anything at all. And what we'll do is we'll do the same measurements in these people. So with these guys, we'll figure out what's the placebo effect, but with this group here, we'll say this is the real effect of brain stimulation. Hopefully you have to figure out what's happening. So we're going to measure a few things. One is the amount of pain, and that's really obvious, and it's really easy to measure that. We ask people, how much pain are you in? Really nice, simple scale. But what's more important for us is we want to see, we may be able to reduce people's pain, but can we improve their function? And we know that some people will have pain but continue to function. And we want to see, are we decreasing their pain enough so that it can improve the ability for them to use their arm in everyday life? So we also have a number of tasks that we'll ask them about and say, is this actually making a difference for you? And then we assess the pain system. And unfortunately, in order to test the pain system, we have to give nasty, painful stimuli to people. And if I were in Auckland and giving this talk, I wouldn't do this component because we probably wouldn't get too many people sign up for it. But, so in order to test the pain system, we're going to do a few things. So one is we look at a pain threshold. So what we're doing is we're applying a stimulus out here and seeing the signal that goes up to the brain. So we're really testing the little dial in here and how much is it turned up. So we have a transducer that looks like this. Ours is a bit flasher. It's got a little digital dial on it, some flashing lights. But really all we do is we push it on until they say ouch. So we're just looking at what's the threshold. Yep. So you just keep on pushing it on and it records the amount of force, and we say, yep, okay, it takes this amount of force in order for this to be ouch up here, and that tells us how much this dial is turned up. The other thing we do, this little dial down in here, it's even more sensitive when you get continuing pain coming in, because normally when a neuron fires, it fires and then it comes back down to normal and then fires again, comes back down to normal. But if you do lots of stimuli really quickly, it doesn't get a chance to come back down, so it'll fire and it just gets turned up. So in order to test that, we do this test for what we call temporal summation. So in this case, we give lots of painful stimuli in succession. So we get this little pokey thing here, and we poke it on their skin 10 times really hard in the same spot and see how much that hurts. And that's another good test of what's going on in here in the spinal cord. The final thing that we do, so that both of those test the ascending component of the pain system, we want to look at some of the descending inhibitory pathways, some of the pathways that turn down pain. And to test that, one of the pathways that we're really interested in order to test that, we give 2 painful stimuli at the same time. So we take one hand and we put it in a bucket of ice water. It's about 10 degrees. And we'll get them to hold their hand in there for about 2 minutes, if they can last, and that's really painful. It's really sore. So just when it's getting really sore, we poke them on the other side. Yep, it's nice. And we measure their threshold there. So I don't know if you've heard of the kind of the pain inhibits pain thing. One of our inhibitory systems is when you get a new pain, you turn down any other ongoing pains that you have. So with our arm in the bucket in there, we get that painful, and then we give them this and we see how much the pain can be turned down. So that's how we test that system. We have to give them 2 nasty, painful stimuli. Cool. So just in summary, this is the pain system. I showed you this diagram before. It's complex. We know it's complex, but we have a few little tools in our bag, and we know how some of them work. So for some people, we could say, look, you just need a little bit of psychology, and that'll be right. And others, it could be a bit of pharmacology. We just need to change your drugs, and we know how they work, that'll be good. And for others, it could be physiotherapy. We just need to do a bit of a mobilisation here, and then you can go off and you can exercise, follow this program, gradually increase it, and you should be all right. What we want to figure out is where do we put brain stimulation in there. We can figure out what part of this pain system here does it work on, what's it doing, and then we can incorporate that into our package. And it could be that maybe we give someone a bit of brain stimulation before they do these, or maybe while they're doing these. So that's why we need to figure out how it works. Cool. Okay. So just before I finish, I want to thank the Neurological Foundation again. They are sponsoring the study that we will be doing. And also I work in the Health and Rehabilitation Research Institute at AUT University, and they provide a lot of the funding for the research I do there. Cool. Thank you very much.
Thank you, Dr. Lewis. It's a very stimulating talk with a nice mix of technical and lay, especially the pokey bits. I like the pokey bits, yeah. So we have time for a few questions. Would you be prepared to take some?
I can do questions, yeah.
Thank you. So here we are, this gentleman in the front.
Yes, thank you for so inspiring talk. So after having brain stimulation, so the pain level drops, and then how long does it last?
Yep. That's a really good question. So the studies that have been done so far have shown that for about 3 weeks after the treatment period, pain has still been significantly reduced. All the studies that I showed were sham controlled, so they did that same thing that in another group they turned it off. And so the longest that's been shown so far is about 3 weeks after stimulation, so they had a 5-day period and it lasted for 3 weeks. What we want to determine though is that there's been some indication that if you do a tapered protocol, so we'll do 5 days, and then we might do once a week for a couple of weeks, and then once a fortnight, and then once a month. And there's some evidence that that will make it last for longer. Some people have done that with magnetic brain stimulation, and it lasted for six months. So at the moment, 3 weeks, it doesn't seem like a very long period of time, but it could be a useful window to do something. But hopefully if we introduce a tapered protocol, we could stretch it out to 6 months. And it could be that maybe they just need a bit of stimulation every few weeks or so. And it's, with it only 20 minutes, it's pretty easy.
Thank you. That lady over there, thank you.
Mm-hmm. It could do. So that's a neuropathic pain condition. Yep. So I think some of the other studies that I didn't show have looked at neuralgias and have shown that it can be beneficial. It doesn't work for everyone, but on average, people get some pain relief from it.
Thank you.
I'm not sure. You have tdcs units obviously floating around this part of the country. Yep.
Thank you. Lady over here, thank you very much.
I have quite a lot of pain, and all the ordinary analgesics just don't seem to work at all. Now, in the past, when I've had pain, aspirin has been quite effective at dulling it, but that doesn't work now. How many people are in my position who are not able to find a satisfactory analgesic?
A lot of people, because we know that 1 in 6 adults have chronic pain, and they'll all be taking some type of medication, and it's obviously not working for them. So a lot of times, the longer you experience pain, the more changes that can occur in that pain system, and so it can become a bit more difficult. So stopping people before they get chronic pain is probably the best way to do it.
Lady right up the back. Speak loudly.
Hi. I want to know if you're familiar with the lightening process, and if so, what your comment on it is.
I have no idea what the lightening process is. Do you?
Oh, okay.
Can you describe it?
It's something I'm looking into. It's a 3-day program that is run in Auckland for pain management, and from what I can understand, it's about neuro-linguistic reprogramming, and combining that with psychology and physiotherapy. But Phil Parker, who's a British man, has introduced it, and it's all over the world. I'm doing research about it, I'm reading his book, but currently am a little sceptical about the thought of flying to Auckland and spending a couple of $1,000s, but you know, it's a bit evangelical when you look at their website as to the results.
Okay.
Yes,
be careful.
but there is. I think anything that we have to acknowledge, there is a large psychological component to pain, and that psychological influences can turn it down. I mean, you know that yourself. If you're attending to something, if you're watching something, it hurts a lot more. If you're getting an injection and you're watching it, it's really sore. But if the little nurse is distracting you over here, it doesn't hurt as much. So there are some really marked psychological experiences, whether or not there's good scientific evidence that works, but there's still the potential. Yeah.
Gentleman over there, thank you.
Surgery many years ago, and because when it does come up, it gets to the point where I'm nauseous. So I had quite a serious operation done back in 1980 where they took something brain off my head and inverted tumor in the teres. And when I do talk about different things, speak to you, I recall all the pain post-surgery, of course, because it's just so vivid, it almost leaves a lump in the side of my throat to cause nausea. The pain is so vivid. Any ideas on how to, or is that psychological sort of help I may need? Or
Because pain post-surgery is very common. Persistent post-surgical pain is very common, and particularly for invasive surgeries, joint replacements, for example. Up to 1 in 5, 1 in 4 joint people who have a joint replacement might have some ongoing pain. And because one of the areas that's involved, that one of those yellow areas of the brain that I showed is really strongly involved in memory, that you have very strong memories of pain. And so people can start experiencing pain when they even just think about the incident that occurred. It can just turn the whole pain system on and lights it up. I've had similar experiences when I've broken my toe. I stood on it when I was running and I broke it. And I went through a period of time afterwards that my toenail came off when that happened. Anything that touched my toenail, my toe suddenly hurt heaps. It was like really, really sore. But I could then stand on it and it would be fine. But because I had that one memory of it, and it's because pain is such a strong sensory stimulus to trigger that memory. So that's very common.
Okay, thank you. Yeah, thank you.
Okay, one right at the back. Speak loudly, please.
Did you notice any side effects in the patients you had? Both patients who benefited and who didn't. Were there any side effects you noticed?
Yes, so we haven't done the study yet. We have tried it out on a few people. The other studies have reported very minimal side effects. So sometimes people might get a headache afterwards, or they might get a little bit of irritation around where they put the electrodes. But it's quite a safe procedure. Some of the other brain stimulation techniques are a lot more risky, whereas the tdcs is a lot safer.
In the two groups, like the group which benefited and didn't benefit, did you do any studies to see differences between them, psychological or history of the condition?
Yeah, we're going to try and find that out. So we will ask a number of we have a number of psychological questionnaires that our patients will do. So we'll try to find a link. What we want to find out is who does it work in? Is there something about their psychological profile or their pain system that means that it works in these guys? Yeah, so that's a really good point.
So what we can take from all this is that there's a lot more to know, and we're so pleased that Dr. Lewis is working on trying to find some answers. So thank you so much. Please thank Dr. Lewis on our behalf. Dr. Lewis will be here till 3, and then she's going to catch a plane to return to the big smoke. So I'm sure she'll be happy to meet with some of you, perhaps outside, over a cup of coffee. So thank you so much. I'd just like to acknowledge the presence of Professor Dirk de Ridder and to thank him so much for his support here today. The professor is the new Professor of Neurosurgery here in Otago, and on behalf of the Foundation, we'd just like to welcome you and wish you all the best for your future. We're very excited about having you. Thank you. Thank you, ladies and gentlemen. We have a talk on multiple sclerosis here at 1:15. If you care to return for that, that would be lovely. Meantime, cafe's open and there's plenty of other interesting stuff outside. Thank you.